Hello, my name is Braden Pate, and I'm a member of the Vanitzel Lab at the Center for Regenerative Medicine at Boston University. Today I'm going to be presenting my work titled The Validation of a Sickle Cell Disease-Specific iPSC Platform as a Preclinical Screening Tool. Now for some background on the project. Sickle cell disease affects a highly diverse patient population of about 8 million people worldwide and around 100,000 individuals within the United States. Current treatments for sickle cell aim to promote fetal hemoglobin levels, also known as HbF. Now, HbF is the prenatal counterpart to adult globin. It functions very similarly and is unaffected by the sickle cell mutation. Now, after birth, fetal hemoglobin levels begin to significantly drop off as adult globin begins to get expressed. However, based on a patient's background, fetal hemoglobin levels retain in adults at various levels. Now, this genetic variation further contributes to inconsistent patient response to drug therapeutics. So given iPSCs retain the unique genetic background of the individuals they're derived from, we aim to utilize our iPSC-based platform to screen novel therapeutics across a diverse sickle cell disease patient population and provide insight into the variation in patient response. Now, to give an overview of our platform, we specified sickle cell disease patient-derived iPSCs towards the erythroid lineage following a previously established erythroid differentiation protocol. So within the first 2 weeks, we can have cells proliferate as hematopoietic stem and progenitor cells, also known as HSPCs, and then further mature these cells towards the erythroid lineage. During this time, we can dose with HbF inducers, such as hydroxyurea, which is the current main therapeutic option used within the clinic, and other compounds known as RN1 or PGC1 alpha, as well as others. Following the 21-day differentiation, we use flow cytometry to validate the HbF induction, and we've done this across 5 different sickle cell disease backgrounds and 1 healthy control line. Now, to walk you through how we model HbF induction, we can look at a readout on day 21. So here we're looking at flow plots for our 6 different cell lines, again, BU6 being our healthy control, and the other 5 coming from sickle cell backgrounds. On the y-axis, we see the expression of CD235A, also known as glycophorin A, which is a pan-erythroid marker indicating that these cells are within the erythroid lineage. On the x-axis, we're looking at expression of our HbF protein. These upper plots are looking at cells which were treated with water, and the lower plots are cells that were treated with hydroxyurea. Water acts as the appropriate control for hydroxyurea. Now we can do this for multiple repeats within these cell lines, and so to highlight this, we're looking at BU6 with an N of 2, and I overlap these plots. And really what we're trying to focus on is this shift in HbF expression amongst the cells that were dosed with hydroxyurea. This is more clearly seen in a histogram, which we see here. The red plots are clearly indicating a higher expression of HbF, and then best seen within this bar graph, which shows the high induction following treatment with hydroxyurea. Now, we've repeated this for all 6 cell lines and across multiple differentiations, allowing us to get a clear insight into the induction response both within and across patient backgrounds. We're looking at the mean fluorescent intensity, or MFI, relative to the control for each compound. Water acts as a control for hydroxyurea, and DMSO acts as a control for the compound RN1. Now, when we look across all 6 backgrounds, we see clear differences in how these backgrounds are responding to these drug therapeutics. Within our healthy control, BU6, this background responds positively to both inducing agents. Similar in SA170, this background shows a clear positive response to both hydroxyurea and RN1. However, when we look at the backgrounds SS100 or BRSP, these patients don't seem to show much of an induction of HbF. In fact, with SS100, this patient actually shows a decline in HbF expression following treatment with RN1. And in the backgrounds SS24 and SS8, there's sort of a mixed response to the current therapeutics we're testing. Now we can expand this further and test possible other concentrations of these compounds, such as hydroxyurea, which I'll show. Now to expand upon our testing of different concentrations of hydroxyurea, we look at our results from the BU6 background and the SS100 background. Now, the BU6 background shows a higher response at a higher dosage of hydroxyurea. However, SS100 still doesn't respond even at a 4 times higher dosage. Now, this indicates that a lack of HbF induction is not necessarily due to an insufficient dosing. Even more interesting, the results from the SS100 background match the current clinical outcome within this patient. Now, we can further expand our testing into other drugs. For instance, here we're looking at pomalidomide, decitabine, PGC1 alpha, and again RN1. Now, as expected, our healthy control responds fairly well to all these compounds, with the exception of PGC1 alpha. And within our Sickle background, SS100, we see that there's not much of a response, again. However, within the PGC1 alpha treatment, there's a slight induction of HbF, indicating that this could be a possible alternative for this patient. Now, given the self-renewing nature of iPSCs, it means that we have nearly unlimited starting material for our differentiations. This gives our platform a tool to dissect the drug response kinetics, allowing us to pinpoint the exact erythroid progenitor stage targeted by different HbF inducers. Here, I'm expanding on the RN1 compound. Now, all other inducers we add in starting on day 15, but with RN1, we don't add it in until day 18. Now, to explain why, we're looking at flow plots looking at the maturation of erythroid cells. So again, on the y-axis, we have CD235A, but on the x-axis, we have band3, which is an erythroid maturation marker, meaning that as these cells differentiate closer to that day 21 readout time point, more and more cells should be band3 positive. Now, looking at this upper row here, for the cells that are treated with DMSO, we see this clear movement towards band3 positivity, having a nice double positive population on day 20. However, when the cells are treated with RN1, they lack the ability to further mature and stunt their growth. So, we found that if we add in the RN1 compound too early, it stunts the maturation, and so that's why we add in the compound on day 18. To further optimize our platform, we've created an immortalized erythroid progenitor line for each of our backgrounds, which retain the stable immunophenotype that we would want to see. To validate this, we've used flow cytometry to look at, again, CD235A and band3. And for 2 and 4 weeks following immortalization, our cells have the exact signature that we would want to see at the day 18 time point within our differentiations. We've even further validated this with a right game sustain, where we see various erythroid progenitors, proerythroblasts, basophilic erythroblasts, orthochromatic erythroblasts, which again further validates that the immortalized cell lines retain the signature we would need. We've even gone on to show that these cells retain the induction potential following treatment with HbF inducers, looking at both hydroxyurea and RN1. These flow plots, looking at CD235A and HbF, show this shift in HbF following treatment. Again, better visualized as a histogram, and finally as bar graphs, where we see this increase in HbF following treatment with hydroxyurea and RN1 compared to the respective controls. To conclude, I've shown that HbF induction can be modeled in iPSC-derived erythroid cells using various therapeutics and across diverse genetic backgrounds of patients. These findings underline the potential of our sickle cell disease-specific iPSC platform as a preclinical screening tool that factors in genetic diversity. Overall, our platform provides promise for advancing drug development pipelines and improving treatment options for sickle cell disease patients. Thank you for your time.